Hello, good evening. This is Dr.Mj Wesley from Pacesdiaries. We are going to have yet another video for our bedside medicine. This video is about respiratory sounds, or you call it as your good old lung sounds. So, what are the important lung sounds that you and I are going to know, like you and I should know for our day-to-day clinical practice, or we are planning, if you're preparing for some exams like MRCP UK PACES, MD General Medicine, DNB General Medicine, FCPS, or American Board of Internal Medicine. This is extremely important for you, even for undergrads who are preparing for MBBS. So we are going to see some extremely important respiratory sounds, what you and I should know. All right, here we go. We can see the sound number one. Any guess, what is this? This is your bronchial breathing. What is a bronchial breathing? Typically, your inspiratory phase is higher in intensity, number one. Number two, there is no gap between inspiration and expiration. Just try normally breathing. That's your vesicular breathing. There is a gap between inspiration and expiration. So there is no gap between inspiration and expiration, and the inspiratory pitch is much higher than the expiratory pitch. Then it's a bronchial breathing. Typically, you will see this over a cavity, consolidation, and other things. And normally, you can hear the bronchial breathing over the trachea. You can auscultate it over your own trachea. All right. So this is the bronchial breathing. What is it? It's a loud and clear with aspirate or a guttural quality. Expiration and inspiration are of the same duration. Can you see this? As much as inspiration, the same intensity will be for expiration. And normally heard over the trachea and large bronchi, consolidation, tension pneumothorax, above the level of pleural effusion, large superficial smooth-walled cavity, and bronchopleural fistula, all will have bronchial breathing. Let's go to the next sound. All right, what sound is this? This is a coarse crackle. We will come to the fine crackle, but you should know the difference between these two. Coarse crackle typically occurs in both the phases of respiration. It occurs in inspiration and some part of the expiration. While if you see the fine crackles, typically you will hear from mid to late inspiration and not the expiration. And whenever you are hearing a crackle, it's better to do post-tussive auscultation by asking the patient to cough and change the character. If the character is diminished, I mean the crackles are diminished a bit, after the patient coughs, it can be bronchiectasis. All right, fine crackles heard during mid to late inspiration, coarse on both the phases of respiration. It usually starts in the basal part, while coarse crackles, no predilection. It's altered in the body position change, fine crackles, where the coarse crackles, like I said, it alters with coughing. It's not transmitted to mouth, it can be transmitted to mouth. And inspiratory opening of small airways, which held during the previous expiration, is the cause of it, where this is produced by gas passing through airways which undergo intermittent opening and closing. Now let's see this sound. I want you to wait for a few seconds for the sound to come. Just wait for another 10 seconds. You will hear the sound. 10, 9, 8, 7, 6, 5, 4, 3, 2, and 1. This is early to mid inspiratory crackles. These are fine crackles of ILD, for example. All right. Now, I want you to listen to this sound and tell me, what do you think? I hope you guys got it. This is a wheeze. Most commonly, it's an expiratory sound, typically reflect lower airway obstruction. Most commonly found in asthma, bronchiolitis. The wheeze can be monophonic or a polyphonic. Polyphonic, poly, many, various pitch. Monophonic, single pitch. Polyphonic wheeze, typically it's due to widespread narrowing of airways, where monophonic is due to narrowing of a larger airways. Polyphonic seen in asthma, monophonic wheeze seen in tracheomalacia and bronchomalacia. All right, let's hear the sound. This is your stridor. What is a stridor? It's an abnormal high-pitched breath sound produced by turbulent airflow. This is particularly through partially obstructed airway at the level of supraglottis or glottis or subglottis or trachea. Okay, there is something called stertor. It's a heavy snoring inspiratory sound occurring in coma or deep sleep, sometimes due to obstruction of larynx. All right, stertor you can find in choanal stenosis, enlarged tonsils, adenoids, and redundant upper airway tissues. All right, now listen to this sound. This is a pleural rub. Okay, pleural friction rub. It's a low, deep, harsh, grating sound. This is due to the friction of inflamed and roughened pleural surfaces against one another. Courtesy to Dr.Mj page. Thank you. All right, now listen to this sound. This is your bronchophony. All right, whispered sound can be heard clearly. I mean, like the spoken sounds can be heard clearly. This is a sign of consolidation. I'll come to that in a second. Okay, can you guess what is this sound? This is your egophony. I'll come to the explanation. I want you to hear one more sound. This is your whispered pectoral. All right. So what are these things? Bronchophony, increased intensity and the clarity of spoken voice sounds. And egophony, if the patient is trying to tell E, it will become A. It will sound like A. Then whispered pectorality describes an unusually clear transmission of whispered words. All these three indicates pulmonary consolidation. All right. Okay, now let's just quickly review. Fine crackles, typically in the peripheral lung, it's a discontinuous high-pitched inspiratory sounds, typically in ILD, pneumonia, and congestive cardiac failure. Coarse crackles, it can be discontinuous, low-pitched and inspiratory, and both expiratory. But I told you already, close crackles can be in both the phases. This can be seen in conditions such as your bronchiectasis. We have seen about wheeze. Wheeze can be seen in asthma, COPD tumor, or even a foreign body. Then we have seen stridor, seen in the narrowed airway, especially in larynx and trachea, especially typically seen in epiglottitis after extubation. Pleural friction. The causes you just need to know. Pleurisy, pericarditis, and pleural tumor. All right. I hope the short videos helped you a lot. Thank you so much for listening. Have a great day. Please like, share, and subscribe. I will see you guys with yet another video on MRCP UK Paces, or General Internal Medicine, TNB Medicine, and FCPS. We are working hard for you to bring out more and more free content for your bedside medicine. Thank you so much, and best wishes.